Thank you, Alison, and thank you, Philip, for inviting me to speak. It's a great occasion and a great day, and I must say that 3 months after Whitlam's speech, I was born. So this November is my 50th birthday, so you can send a card, but no presents. And I'm also happy that Whitlam did mention the Melbourne Institute in his speech, where Scotland and Ebel were when they first designed Medicare, and it would be, great to try and continue that legacy. What I want to do is, this is a quote that Adam put up at the beginning of his slide as well, actually, about governments being passive payers, and it is an important issue. And as Adam also mentioned, until Medibank Private was listed on the stock market a few years ago, health insurers were also passive payers of bills, much more so than government was. But things are changing. And I think, compared to the US, where health insurers have been very active purchasers of care for decades now, we are still way behind. I want to just talk about, do we understand incentives in Medicare? Clearly, I don't think we do. Moving towards value-based Medicare, and that's picking up on some of the issues that Adam looked at. What are the current reforms in payment mechanisms within Australia? And then look at the evidence. Do incentives work? And then I wanted to say a few things about what would be nice to happen in the next 50 years. I guess in one sense, the delivery of the Commonwealth funding, and that funding creates incentives, is enshrined in legislation and in the Federation of Australia. So these things are set in stone. It's very easy to outline the problems and perverse incentives that exist due to that legislation. But that means they're also very, very constrained in providing bold solutions, because we do actually practically, pragmatically have to operate within that. And I think, it's also important to understand that really if we want to change health policy, we really need to influence legislation as it is changed as well. And occasionally there are kind of occasions when legislation is changed, and we need to be in there at the Senate committees, at other things, trying to put our evidence at that point, because once legislation is set, that's it for decades to come. In my view, that's often our biggest chance to influence policy. The second thing is that doctors' fees are unregulated. This is rare in the developed world. It happens in many low and middle-income countries as they're developing, but for us it is unusual, which means that changing schedule rebates and subsidies might have not very much impact, because doctors can say if the rebate is increased or reduced, doctors can simply change the level of the fee to capture that as their own earnings, and the patient doesn't experience any change in the co-payment. So that's an issue which stops us using Medicare as a relative price schedule that is done in the US, where Medicare fees are fixed, they're paid directly to doctors and not to patients. And this also means that the financial risk is shifted entirely onto government and patients. So the professions don't bear much financial risk because they can change prices as they want in response to anything that happens to them. So that's an important part of the setup, something that we can't change. And over the years, and there's been persistent cost blowouts in Medicare. Every time you need for mental health items, chronic disease management, there's a string of these where, after hours, there's a string of these where the graph just goes like that over a number of years, and then a few years later the government's trying to change it all and reduce it and change the items again. And that's because we don't understand what's going on, or at least the Department of Health don't appear to understand, or if they do understand, they can't do very much about it. And we forget that Medicare is a subsidy. It pays patients, not doctors. or providers. The subsidy is designed to go to patients. Only when there's bulk billing, I guess doctors have it as their own income, but certainly it's designed as a subsidy system so that there's an extra link between what doctors get as their earnings influence their behaviour. That depends on what patients do. The small dollar signs in that suggest the flow of funds from government to patients and then to Medicare. But what we don't understand is things that economists call elasticities, which are very simple concepts in practice, which tells how responsive are patients to more or less or higher or lower rebate. And supply elasticity is how responsive are doctors to a higher or lower rebate. Elasticity is a single number, which is calculated in sometimes a complicated way, but we don't know them. There's no published elasticities. So how can the Department of Health possibly predict what the changes in costs are going to be when they change rebates without knowledge of these elasticities? And it's a fundamental, basic thing of economics. And maybe they do know them. Maybe they do use estimates within the department, but just we don't know about it, and academic health economists have never been asked to calculate them. Those are some kind of problems about us and not understanding how incentives work within Medicare at the moment, and that's a real issue. Now, at a minimum, the passive payer, at a minimum, you would think they're interested in accountability about we're giving lots of taxpayers' money out to providers. We really know what they're doing with it. We want to know what they're doing with it. Are they improving things? Are they enhancing performance and costs and health outcomes? And that's one of the motivations for accountable care organizations in the US, which and accountability isn't really mentioned here at all in the context of healthcare funding. The desire by governments to pay for only what is effective and cost-effective. We can see that in PBSC clearly, where there has been a major policy enshrined in legislation to ensure that happens. But states don't have, an equivalent of when state governments buy devices and that kind of thing. We also use incentives to change the distribution of healthcare providers. Access to care is important as well, where doctors go. We know there's a big issue in getting doctors into rural areas. There's a whole load of incentive schemes which are thrown at doctors, most of which have never been evaluated either. So access to care is very important in low socioeconomic groups, but also in rural areas, which again is often off the radar. But where the doctors are very important in terms of what services they provide and to whom. And that's a bit like, sending the wrong soldiers to the front line, and we won't win. And Adam's talked a lot about overdiagnosis, overtreatment, reducing waste and low-value care, and that's important, but also it's combining the desire for high quality and reduced cost. And issues in the US have picked both of those issues up. Efficiency is not just about effectiveness or benefits or harms, it's about cost as well. And that's often a difficult message for health economists to get across. Medical profession understands benefits to patients much more clearly, and so the emphasis on low-value care is a really great place to start. There's lots of stuff going on at the moment, and in the last few years, there's probably the most been going on in terms of this that there has since Medicare began. In the middle there, we have healthcare homes, which is for the first time moving away from fee-for-service payment for patients with chronic disease. So doctors will, in that trial starting this year, doctors who are participating in this scheme will not be able to claim Medicare fees for visits. They will get a fixed, I'll say the C word, capitation payment for the services that are provided at 3 levels depending on the patient's risk. So that's again, a really good step and a brave step away from fee-for-service within the context of the current legislation. So these things are possible. On the bottom right is the MBS review. One of the recommendations about changing the rebates for procedures, increasing the rebates for GP procedures to the same level as specialist rebates for those exact same procedures. And that's, that's planned to happen. So a lot of these recommendations are starting to happen. And again, but changing the relative prices, what impact will that have? And I think we don't know. Doctors may provide more of those procedures. Is this going to be another Medicare cost blowout? I don't know. I mean, there's only 30,000 procedures a year done by GPs, which are minor surgical procedures, mostly in rural areas. So how's that going to play out? What are going to be the reactions to doctors to that? And maybe the department has done some estimates of that, but I'd like to know what elasticities they used, if any. IPA, the pricing authority, are beginning in the hospital side to look at value-based pricing of hospital services. At the minute, we've got DRG payment, which is a kind of a fee-for-service for hospital services, if you like. And the DRG is a bit of a bundled payment already. But they're trying to, not pay hospitals for hospital-acquired complications and other things like that. And that's within that, there's also not paying hospitals for unplanned readmissions. And that's beginning to happen from this year. But Medibank are way ahead in doing this. They're already doing it, and they started doing it a couple of years ago. And so they've been, really looking at the contracts with the private hospitals. Clearly, Medibank don't have a direct impact on physician behaviour because they don't pay doctors directly, apart from through some gap arrangements. But really, they're really trying to look at these contracts with hospitals to try and do that. So as in the US, the private insurers often lead the way in these kind of initiatives. So there's a lot happening, and again, there are evaluations of some of these, but not everything. Although we talked about randomized trials earlier on, it's randomized trials of this stuff as well that we need to do. Healthcare homes are being evaluated, but I'm not sure that they have a control group. One thing I didn't mention is the practice incentives program, which is also being redesigned as well into a quality improvement scheme, but not a pay for performance program. So it's all about quality improvement and paying for participation in quality improvement. So there's lots happening at the moment, and it's kind of exciting to look at all this happening and being involved with some of it. But we are still healthily sceptical about what these various schemes will deliver. But they certainly are going in the right direction. Look what's happening in the US. So the bottom part of this slide is something that US Medicare, the Center for Medicaid Services, published in 2015, to have 85% of all Medicare fee-for-service payments tied to quality or value. To have 30% of Medicare payments tied to quality or value through alternative payment models by 2016, 2018. So, they are way ahead, and I think because, they started publicly reporting and privately reporting, but publicly reporting information on quality across various health services, 10 or 15 years ago now. They built pay for performance models onto that. And with trying to incorporate costs into that, they're looking at pay for performance and reducing costs and rewarding for both of them together, okay? By looking at shared savings models, which is what has been talked about in terms of Pharmac, where they have a fixed budget, and that budget is fixed. It's a hard budget. It's not soft. If you're going to deficit, nobody's going to bail you out. If you have a surplus, well, you can keep some of that. So that's where the issue of cost has begun to come into it in the US, where they're trying to combine these quality payments with the fixed budgets, and that's the main innovation that we're yet to see happen here. Do they work? Well, now, toss a coin, and you'll find out. So we've done a number of reviews over the years of this, and systematic reviews for Cochrane, and there's some consistent measures come out of this. A lot of the reviews say, well, we're not really sure, but two things come out of it. First, I've posed as a question: does incentive design matter? As economists, we think it should. In many other industries and places it does. How we design these incentives matter. And a lot of these incentives have been designed badly. Why have they been designed badly? In our view, well, it's because essentially it's a negotiation. You're looking at doctors' incomes. Doctors want to extract as much money from the government as possible and not change their behaviour at all. Government want to extract as much behaviour change from doctors as possible and not pay them anything to do that. So that negotiation, which we've had alluded to, is important because it waters down the effects of incentives. And that's just how it is. So that's one reason. So we can design all these fancy incentive schemes, paying for changes in improvements in performance over time. But there's evidence from our reviews that some of those more fancy kind of design features don't matter. They don't make a difference. So we need to think carefully about that. And is it something that we can actually do something about? The other thing is the quality of the evaluations. They're improving over time. Some randomized trials, some of the quasi-experimental studies. But for those better designed evaluations, it's not just 50%. There's a chance of half of these studies working. It's down to 30% for those better designed evaluations. So the chances of an effect are much lower for those better designed quality studies. But, there clearly are situations where incentives do work and contexts where they do work. And that, should be the focus. And clearly, incentives aren't everything. Economists do assume that people respond to incentives, but a lot of people don't. There's variation in that. So, and as we've seen in policy terms, legislation, regulation, there's a lot of other things that change behaviour as well as incentives. But the role of incentives within that mix is still important to draw out because it is the Commonwealth Government's only way to change behaviour is through funding. Okay. Solutions. More experiments. Now it is very hard for DHS to run two separate payment systems in Medicare. And that what probably stops them from doing any kind of randomization or trials within Medicare, even though administratively changing a payment from one group or another is an issue. So I think we do need to think about that because, it means that we might actually save a lot of money from all these cost blowouts, which we're going to avoid in the future. We need trusted data access and linkage. The reason why we don't know anything about healthcare elasticities of demand or supply is because we haven't had the data. Give us the data, will help. And I do think we need an independent centre for Medicare and healthcare financing research. That's what Medicare is the biggest thing that's happened in Australia in health insurance for a number of years. And there's virtually no research on it. That's changing. People are getting bits of data linked to surveys, and I think that's starting to get there, but we need a lot more. In the US, you talk to people there, and the biggest impact of research has been when researchers in the US have Medicare data. They've had it for a long time. Every researcher's got the same set of Medicare data, doing lots of cool things with it. The research that comes out of the Centre for Medicare Services and the government is less trusted than the academic research because there's more of it, and just the things that you can do with it, which you can't even think about now, is enormous. So that's very important. We do need smarter design of incentives. I've said that we're not sure whether design matters, but part of that is about the negotiation and how that is approached. And we've heard that in a number of contexts with respect to pharmaceutical pricing and others, that governments generally are bad negotiators. And we need to try and strengthen that somehow. We do need to measure and privately first and publicly report data on quality and health outcomes. The healthcare system measures deaths. It doesn't measure success. We need, and that part of that is patient-reported outcome measures, routine measurement of health status before and after you have an operation, which is great. And then trying to tie payments to value, which is quality and cost. Thank you very much.